We're going to talk about informed decision making, and specifically things related to informed consent. And the question is this a topic solely for end-of-life care or hospice? And the answer is no. Actually, I know that most of you, medical trainees and nursing trainees, won't go into end-of-life care, but informed decision making would probably play an important role in whatever you're doing. Starting from the 1950s all the way to 60s and 70s, there were several issues about patients complaining that they weren't told or they weren't given a chance to decide for themselves, or the doctors did, with the help of, with the assistance of the ancillary staff, did something that if given a chance to decide, they wouldn't have agreed to. In the developed countries, that would be like 1950s, 1960s, 1970s. During the 1950s, 1960s, 1970s, the patients were demanding the right to decide. Now, in end-of-life care, well, the cases were very well publicized. People were talking about it. At least people were talking about it, at least in the United States and United Kingdom and Canada. There are cases of people who are in a vegetative state, and their parents and their families are saying, well, she doesn't want to live like that for very long. Living as if you're not connected to the world, but your heart and brain are functioning. And so the family are saying that, don't keep on feeding her. No, even worse than that, more glaring than that, or more sensational than that, would be patients who are awake, alert, but then they feel like their life is so miserable and they're attached to this ventilator for some reason, like they have a spinal cord problem, or people who are experiencing Alzheimer's and they know that they'll keep on going, and then pretty soon they'll live a life. They are not even sure how alert or aware they are, but in their minds they don't want to go there. And is there a way for them to die more quickly? Or a more common scenario would be people in the wards. If you're rounding in the medical rooms, like general medical rooms, or in the intensive care unit, receiving life-prolonging measures could be, it might have something to do with receiving nutrition, like chew feeding, or receiving something as basic as air, like ventilators, and they're very drowsy, or they're comatose, and the family is saying, if he or she can talk, she'd tell you to stop all those things because she doesn't want to keep on going for several days or several weeks or even months being that way. And so these are the cases related to end-of-life care. Now, during these times, medicine was also booming, right? So post-World War II, it's like the scientific and technological boom in modern medicine, and medical industry was given birth to, and the money-making, highly sophisticated and money-earning medical care industry was born. And part of the manpower of this huge, gigantic medical industry, unfortunately, were the healthcare providers. They create the products on top, and could be all sorts of things supporting the various kinds of diagnostics and treatment-related gadgets and drugs. And the downstream would be the doctors telling the patients that they need this or that, and and of course you have to make the doctors happy by giving them all the stuff that they like, so that they keep on doing what you want them to do. Trips abroad, conferences, trips / not really trips, but vacation stuff abroad, and conferences in 5-star hotel. They sit down, living a very luxurious, rich life, which is very disturbing, because the reason why patients trusted healthcare providers in the past, like early 20th century, is because these are people who are willing to do all sorts of things, sacrifice all sorts of things to take care of them, even if that doesn't pay well, or even if the job is difficult. You wake up at night, patients knock on your door, because there's no telephones yet, or there's no other doctor in town, or you don't have a car to go to the nearest big medical center, which is very far. They're like in huge cities, and even if you get there, you probably won't have any resources to get in, or not everyone can get in. So they call you up, and then you ride your horse, or you walk towards their house and stay up all night, and they thank you, they give you a little bit of. Doctors are not like the richest guys in town, or they don't have unusually high incomes compared to everyone else. That happened later on when the industry decided that, it's nice to keep these people happy, so they'll happily do whatever we want them to do. Of course, they don't actually think that way. They think they're doing everything in the name of science and whatnot. But anyway, if you actually just sit down and try to figure out your hidden interests and values, you'll figure it out yourself. So it's not, we'll just stop there. So these were times when people were demanding the right to decide for themselves. Autonomy, self-determination, and informed decision-making and informed consent are based mainly on the idea of autonomy, the right for people to decide for themselves, self-determination, as opposed to the earlier version of paternalistic, meaning I trust my doctor, look at how he lives or how she lives. So much sacrifice. I mean, obviously they know a lot. Of course, they really don't know a lot during that time, but as far as care of people who are sick is concerned, they're probably the best people to go to. 19th century, early 20th century, and why wouldn't I trust them? I trust their values. I know they'll decide what's good for me, and of course, that the Western countries would have the Judeo-Christian or Catholic values. So I'm pretty sure that they do for me what they'll want others to do for them. Right? So why shouldn't I trust them? There's a lot of trust involved and faith in this person who will probably do everything that he can for your good. So that's beneficence. So you trust this person. Probably this person is not going to do anything harmful to you. I mean, you don't even think that way, right? So, but then that also changed. Once you pour goodies and money and things like that into the system and turn the previously very self-sacrificing people into people who walk around carrying a whole bunch of self-interest. It could be the 3 Ps. The 3 Ps are prestige, go up the stage and you're so good, you're a brilliant lecturer, and then you tell them about the latest drugs and the latest tests, and it's RCTs and scientifically based, and you look very smart, so that's prestige. Power, you're not that smart, but you know how to kiss enough behinds that you actually ended up getting to the right position, or you know how to make a whole bunch of people up there happy so that you can be up there later on in life. So that's power. And possession, the 3rd P. Possession is in wealth, cars. Your kids go to very expensive schools. You have a very big house, and you're in a profession that's on top of the socioeconomic totem pole, right? So once you introduce all these things and interests, and once you start pouring money into it, of course, who's pouring money? The people who are earning a lot to keep the doctors happily doing and following whatever they want them to do. So that's the huge, gigantic medical care industry. So once you have that, then you have people doing stuff for their own interest, and you start losing more and more of the selflessness and the compassion and the caring and the sacrifices. And suddenly you're in a place where people who are sacrificing and compassionate and doing selfless stuff will be very few, very hard to find, right? So like you can have a medical school class. I'm not saying what class or what country or what institution of 170 or 180 medical students, and you can have like barely a handful of people doing exactly that, even if the entire institution is saying that they're creating doctors like that. It's like having all the goodies, but then also being able to say that you're such a good profession, and then people would ask, well, I don't see you doing that. And then you point to the 5 or 6 out of 100 or so doctors who are there doing exactly what you tell everyone you're doing. Even if you're not doing it, you're actually doing something of the opposite. You're actually indirectly, if you really try to think about it, supporting a system that's making life difficult for those people who are doing good. But anyway, that's not the topic right now. It's about self-determination, and some ethicists and lawyers would also say that it's also about beneficence in several perspectives. Like it's beneficence because it's about doing good, but who's going to decide what's good for them? Well, the doctors will be the paternalistic approach or trusting approach. Maybe if you're dealing with something like death and dying, or something that's a very important decision that risks a lot of things, like a procedure or a surgery that costs a lot, would impact on their livelihood or their future life, it really drains their resources, or might cause harm or disability or whatnot, or something that would determine the few remaining weeks of your life, would determine how you live the few remaining months or weeks of your life, or that will determine whether you live or die. Well, maybe the best person to decide is not the doctor or the nurses or any other healthcare provider or any PhD in ethics or any legal luminary or a smart lawyer, but maybe it's the person who's experiencing the sickness or the person who's affected by this life-threatening condition. Well, the doctor's limitations are very obvious. Doctors are saying they know a lot. Nowadays, it's not really about doing a lot, caring, sacrificing, trying their best. It's not really like that. It's more like we know a lot, we have science, we have clinical trials, and we know all these things, so we know what's good for you. But then, what's good for someone who's about to die? And even if you did like really robust surveys, epidemiological studies or clinical studies, what's the impact of those findings? Nothing really. It just gives you some ideas and clues. What you really need to do is just, sit down and try to talk to this person and help them decide what's important for them, what their concept of a good death is, what their concept of life, the last 3 weeks of life that's worth living is. And you cannot define it for them. Like, no matter what happens, your pain should be below 3 or 4, because we did this survey and, 70% of everyone said that. But that's assuming that there are no other values more important than that. I can tell you, being with family and sharing time with family with a brain that's not fogged up with opioid is much more important than that for most people, right? So that's not going to show up in surveys, or most of the surveys that we cite about this 3 or 4 out of 10 pain scale, or and then we say it's our duty so that they're not in pain. But for many people, there are things which are much more important than that. And you have several people saying that, I know my pain is still pretty bad. I can score it about 6 to 7 out of 10, but then, I only have like 2 weeks to go. And during the last week, I might not even be able to talk to my kids anymore or my siblings anymore. I'd rather bear and suffer the 6 to 7 intensity out of 10 intensity pain than be fogged up while they're here and not share decent time with them. I think I can handle that kind of pain, and I'll be happier if you don't drug me up that much. Just keep it at the 6, and that's good. And I cannot tell the patient, no, it has to be a 3 or 4 according to our textbook or according to our clinical consultant who seems to know what they're talking about. Well, I can tell you they don't, but of course it also points to the growing impersonality, the fact that modern medicine becoming more and more impersonal. And that's what you get when you always rely on randomized controlled trials and science and forget about the 70% of things. That's science, clinical trials, and the objective view that the person is a body that you can study, and that's like 30% of everything. That gives you the tools. But when you actually handle the patient, that's like the actual caring stuff. That's like 70% of everything. So what happened was we are so focused on the 30% that we think there's nothing else involved, right? So this is what we know, this is what you get. That actually happened in childbirth. Childbirth used to be a very personal thing. It's a birth of a new life, and then there's this growth of modern medicine handling childbirth, and became too unruly. And people were doing stuff that they shouldn't be doing, and then it became very impersonal. The child was separated from the mom, the dad was separated from everything, and you're just stuck in this very impersonal place. And then you go home, and then you are happy with your kid. And 20 to 30 years ago, people realized how wrong that was. And most of those things they were doing wasn't even called for. For several centuries, a lot of women, without any huge risks or anything, can experienced a very difficult but memorable childbirth, right? It's the birth of a human being, and it disappeared, and then people realized how heavily impersonal it became and how heavily commercialized it became. So now they're turning the dials down a little bit, and if you're not careful, that's going to happen to end of life care. It happened at the beginning of life. Now it's going to happen at the end of life. It's going to be a very impersonal treatment of dying people, and that's going to be a very terrible thing. I think it's going there. I hope not, but we can always pray. But anyway, so it's beneficence. That's the other argument for beneficence is it's good for the patient because you're treating them with dignity and respect. What's more good than that, right? I mean, somebody who's about to die being treated with respect, that's the ultimate good, or that's one of the more important goods, right? So, and of course, on the practical side, you got their agreement. That's what they think is good for them. So it will be easier for everyone to take care of the patient and achieve whatever that good is, comfort, being with family, and things like that, instead of just deciding for the patient and not even asking the patient what they want and doing your own thing, even if the patient doesn't want it. Then how cooperative will that patient be? How happy will that patient be? And you're supposed to try to optimize his final days of life, So those are the arguments for beneficence, but mainly it's self-determination and autonomy. I guess the other thing that led to this push towards self-determination and autonomy, instead of just making the doctors decide for them, which is related to the commercialized medical care industry, would be the commercialization itself. What do you do when you go out and make a very important decision in your life? For example, buying a house or buying a car. You go to the car dealer, and then the dealer tells you about the car and the insurance and how you can pay for it, and you expect them to tell you the truth about everything before you buy the car, because it's a very significant investment on your part. You might be paying for that car for the next 3 years or for the next 5 years, down payment, and then you pay it for like 3 years or 5 years. That's a very important investment. You don't want them to leave out very important information about the car, or something that's not good about the car, but they decided not to tell you because they want you to buy the car. So you want them to tell you everything, the good that you'll get out of it, the chances that you'll get that good, how much it will cost, and what risks and what would happen to you if you buy the car. Are there bad stuff that might happen? Or do you have an alternative choice? Maybe there's something that is almost as good as that, but more affordable. Did they tell you about your choices? Right? So, or maybe they have a better car. They just wanted to sell this aging model out, and they didn't tell you about the better alternative. So what are we talking about? We're talking about a client who wants to buy a car. And there are laws protecting the client. You have to supply the client with enough information for them to decide whether they really want a car or not. Okay? So now, the medical care industry became very impersonal and very commercialized. Now people started thinking that the industry itself was the one who started looking at people as clients, like managed care corporations, big private, semi-private medical care institutions, even government institutions are dependent on some form of income, right? And nobody wants to be in the red. So, and started looking at patients as clients, and you have to make the client happy, and then they sign this happy form, client satisfaction survey, just like entering a bank or doing grocery. You sign this client satisfaction survey, or you can be cute about it, and there's this smiley face and sad face, and they ask you which one you want after the service has been rendered by the bank or whatever shop you entered in. It's same idea. Same idea being done in the hospitals and the clinic and things like that. So they're clients, and clients need information about everything, so that they can decide, well, if they really want it, because they're paying, or their insurance is paying. Of course, they're paying for their insurance. That's their insurance. So that's a very different kind of perspective. That's a very commercialized perspective. When there's not a lot of money involved, there wasn't that kind of perspective. It's more of a sacrificing person who's doing everything that he can to take care of you for whatever personal reason or whatever happiness he can get out of the job. But certainly it's not a lot of money. And you don't have this industry that's above, that's running the show. Yeah. So there's, the industry became huge, almost rivaling the energy industry, as big as the energy industry, or almost as big as the energy industry, one of the top 5 major global industries, and suddenly everything's changed, You're not just talking about a country doctor going from house to house. You're talking about doctors prescribing stuff being made by huge mega corporations, doing surgeries using tools created by and being sold by the industry, and all those things. And just money flows all over the place, and then money to make them happy, and then they go and do their fancy 5-star conference activities, and of course the patients are not part of the loop. Anyway, so now the question is that good or bad? Well, I don't think it is, but will the doctors, or will the providers be willing to let go of it? I don't think they will be willing to let go of it, which is very unfortunate. So you start things during the 1960s, 1970s, and then you think you can control it, but once tempted, you just keep on going. And now we're too far gone. And even people in the 1960s and 1970s who accepted some of the commercialization would cringe at what we're doing right now. But anyway, so that's informed decision making and informed consent.